All right, so let's recap all of this on one slide. And what I'm going to try and do is I'm going to try and put the really big stuff in red here so that at least you can kind of focus in on that. But a lot of the stuff on here is relatively high yield. You have to make these associations. Okay, so first off, acute hemolytic reaction. Again, what's the mechanism? We already said it's going to be, usually it's going to be the donor red blood cells destroyed by the recipient antibodies. Now that's going to be a little bit different if we're talking about plasma transfusions, right? If we're talking about a classic red blood cell transfusion, right, this is going to be the presentation. If you want all of the details on that, you can go back to the slide and watch that video. But in general, it's usually going to be the donor red blood cells that are destroyed. And again, this is going to be a type 2 hypersensitivity. Classically is going to be happening during the transfusion. It's going to kind of make this stand out. You can see there's really only one other classic presentation that happens during the transfusion. Again, symptoms of hemolysis are going to be present. Things like jaundice, scleral icterus, pain at the IV site, right? Hypotension, tachycardia are all going to be very classic. And when you do the labs on this patient, these patients will typically have a positive Coombs test, okay? And they'll have the classic hemolysis lab markers, right? Elevation, LDH, bilirubin. When we're talking about step 1, we already said, number one thing every time, immediate cessation of the transfusion. That's going to be the first thing that you want to do. You want to stop the transfusion if it's happening, if the patient's having symptoms while we're transfusing them. And then you can do things like a type and screen. Specifically on step 1, they usually refer to this as more just saying like, hey, would you do a Coombs test, right? A direct Coombs test is what we're trying to do. We're trying to see if there's antibodies on the surface of the red blood cell that are marking them for destruction. And the key cause of this, right, the key association is going to be ABO incompatibility of the blood antigens, right, of the major antigens. When we're talking about delayed hemolytic reactions, we're usually talking about the minor antigens that are going to be causing a lot of the responses. And for that reason, we think of this as having more of the mild symptoms. Again, an anamnestic response is very classic. It's going to take repeated exposures to generate that response. It's also a type 2 hypersensitivity, right, very similar, just pathophysiology to the acute hemolytic reaction. The big differentiating factor here is the timeline, right? It's going to be weeks, right? We could be 6 weeks out and the patient might start to have symptoms. None of these other reactions really present that way. So that makes it stand out. If you did a Coombs test, right, it would be positive because you have antibodies bound to the surface of the red blood cells. You have red blood cell lysis, right? You'd have these markers elevated if it was severe. But in general, self-limited. And the classic presentation, again, frequent blood transfusions because it takes time to generate that anamnestic response, right? Same thing, IV drug use, we already kind of talked about that also for the same reasons, right? You're exposed to that minor antigen repeatedly, right? From, using needles that may have been contaminated from previous use, for example. Okay, febrile non-hemolytic reaction, right? Classic mechanism is this donor white blood cell cytokine leak, usually hours after the transfusion. Symptoms tend to be mild overall. The classic thing in this patient, like we talked about, very classic to present in a pediatric patient, and in future occurrences, right, you want to make sure you use the leukoreduced blood products. So TRALI, transfusion-related acute lung injury, very similar presentation to like an ARDS, right, pulmonary edema from the neutrophil priming and activation. These patients, like we said, classically dyspnea, increasing oxygen requirements, and I'm actually going to highlight those in red because that's particularly high yield. It actually kind of makes this stand out a little bit. That, along with the chest X-ray findings that we talked about, you have pulmonary edema, that being very classic for this presentation. Okay, and again, this resolves spontaneously. Also remember, fresh frozen plasma or platelet transfusions tend to be very classic for precipitating this transfusion reaction in particular. And then finally, the anaphylactic reaction, we already kind of talked about the pathophysiology here. It's really these recipient anti-IgA, IgE antibodies that are causing most of the problems here. And again, this is a type 1 hypersensitivity, and the classic presentation is going to present with things like urticaria and wheezing, okay, which is very classic for a type 1 hypersensitivity reaction, and you want to avoid IgA in the blood on future occurrences. Very classically presented with the IgA deficiency. So hopefully this helps simplify this a little bit for you. I think there's some key things to look for with each of these different pathologies. Once you find that key thing, though, they might ask you about something else specific with the disease. So that's where it helps to kind of understand the whole picture of what's going on so that you don't miss anything. Even if you recognize the pathology, you might still have to know a little bit more to get the question right.